We're going to give about one more minute to let attendees get into the meeting. It looks like we might have a small group today, which means if you have questions, you're likely to get to ask them, and questions will be done via the chat. All right, good afternoon, everyone, and thank you so much for joining. My name is Chris Meyer. I'm a research analyst here at the Maryland Center on Economic Policy. For those of you who aren't familiar with our organization, we are a nonpartisan, nonprofit think tank that works to build broadly and equitably shared prosperity across Maryland through policy. We have two excellent speakers today who I'm very excited about. So we are talking, as I'm sure everyone here knows, about how Maryland's investments in Medicaid-funded home care can move racial equity forward in our state or backward, and especially how current policies have historically moved equity backward. We'll be hearing from April Sims, who is a home care worker, and she'll be sharing her experiences. And then we'll be hearing from Sandy Ballin, who is a senior attorney at Disability Rights Maryland, who will share the perspective of consumers and Marylanders with disabilities with home care. Before that, I'm going to start out with just a little bit of context. I am going to be I am planning to share screen, but it looks like I need to be let's see. Excellent. So one of our core principles as an organization is that fiscal policy, so that means both the state budget and our decisions about tax policy and raising the revenue we need, is a matter of justice. The decisions that we make about the state budget affect whether children are able to get a good education, whether families are able to keep a roof over their head and put food on the table, whether people are able to get the health care they need, whether people have access to opportunity or they're locked out of opportunity, or in too many cases, physically locked up. And furthermore, we believe that good intentions are not enough. In order to make good policy that advances equity, we need good data and good values-driven analysis, which is why we have been for many years working on what we call our Budgeting for Opportunity series, which looks at different aspects of the state budget through a racial equity lens. So what we mean by racial equity is that we want to build a state in which a person's racial or ethnic background doesn't determine their chances in life, doesn't determine their health outcomes, their employment outcomes, their income. And we are recommending that the state should actually should institutionalize equity analysis of the budget into the state budget process. So this case study on home care is the latest entry in this series, and it serves as sort of a model of what that institutionalized budget equity analysis can look like. I'm just going to give a brief overview of our recommendations about budget equity analysis in general. First off, we believe that racial and ethnic equity analysis should be built into the annual budget process institutionally. There's already, during the legislative session each year, certain analyses that legislative staff do on every part of the budget. They look at expenditures and personnel, various performance measures, and factors in the overall landscape that affect policies. So we are recommending that this be expanded to include analysis of how the budget decisions advance or hinder racial equity. This is especially important right now because a recent constitutional amendment has strengthened the legislature's power to make changes to the budget introduced by the governor, which means a more open and inclusive process that then needs good information to produce good policy outcomes. We have 5 main recommendations about how institutionalized budget equity analysis should be done. First, it needs to start from a strong foundation, which means that the staff who do these analyses need to understand equity concepts. They need to understand the historical context that created our current inequitable power structures. And they need to understand that racial equity analysis is not about colorblind processes, but about moving us toward a more equitable world. Analysis has to be systematic. It needs to start early in the budget process. It needs to have sufficient resources and staff who are able to actually do a good job and not simply check a box. Equity analysis needs to center marginalized communities' perspectives. People are experts in their own experiences, and staff analysts, while they have certain expertise, cannot substitute for people in directly affected communities. Next, budget equity analysis has to be guided by high quality data. We'll be digging into this a little bit more today. We need to have a strong foundation of data disaggregated by race and ethnicity, as well as other characteristics like gender, to actually know how our policy choices are affecting people. And then finally, any budget equity analysis has to be prominent and accessible. That means both the general public is able to find this analysis easily and see it and understand it, and that this analysis needs to get in front of policymakers' eyes, whether they want to look at it or not. So last winter, we put together a case study looking at Maryland's budget for Medicaid-funded home and community-based services as a model of what this can look like. That's what we'll be talking about today, and especially the 2 speakers who will be, I'll be handing it over to very soon. So this analysis was based on an established framework by the organization Race Forward that puts together templates that organizations and governments can use to do racial equity analysis. So what are home and community-based services, which home care is a subset of? That means help with the activities of daily living for people who, due to their age or a health condition or disability, need assistance with basic activities such as eating, cooking, shopping, and allowing people to remain in their home rather than an institutional context. Medicaid is by far the largest payer for these services, which means that state policy choices have a huge effect on what the entire industry looks like. And in Maryland, the way that this is structured, which I think many people on this webinar probably know, is that home care is provided by private agencies that employ individual workers and contract with the state. So there are really important equity implications to the policy choices we make around this, which has to do with who the stakeholders are. Consumers of home care are essentially, by definition, people with a disability or with a health condition that requires them to have assistance in activities of daily living. For Medicaid-funded care, to be eligible, people need to either have very low incomes or a combination of low wealth and high medical costs. So access to care is a central aspect of really equity in our healthcare system overall. There are also important equity implications because, as I'll get into in just a moment, uh, home care workers are overwhelmingly people of color. 60% of home care workers in Maryland are Black, 84% are women. And then we have people who are affected and harmed by inadequate access to care, namely people who are on a wait list for care and people who generally family members are caring for those typically caring for loved ones without receiving without being paid, and we actually have very little data on these populations, but uh, harmful impacts of policy choices on those groups are very likely to have equity implications. So as our two other speakers will be getting into much more, there are three big problems with our current Medicaid-funded home care system. First off, there is a severe workforce shortage that undermines access to care. And this is especially going to become more severe as our population continues to age in coming years. Uh, Home care workers also typically take home very low wages. This is an equity issue in and of itself because of who home care workers are. It also makes it difficult to recruit and retain qualified workers, which then reduces access to care. Um, an important aspect of low wages is independent contractor misclassification, which is something that there's some good news about that I'll be getting to in a moment. But historically, a large number of home care workers have been misclassified by their employers that the state contracts with as independent contractors rather than employees. What that means is that they're denied uh, bedrock worker protections like minimum wage and overtime protection. It shifts tax burdens onto workers and off of employers. Um, and then finally, a big question about low wages is whether the current payment rates that Medicaid pays to agencies are adequate to support better wages. And then finally, hindering any solution to these problems is that we currently have extremely sparse data on any of the stakeholder groups involved in home care. That means who consumers are, people actually receiving the care, demographics of the waitlist registers. We have very little data on who home care workers are, the number of workers even, their demographics, and the wages they take home. We know very little about the cost structure of the agencies that deliver this care, which means that we don't have good information on whether payment rates from Medicaid are adequate to support decent wages. And then we have essentially zero data at all on informal caregivers. So our case study made recommendations around improving data collection to make sure we have the information we need, instituting wage standards to make sure that home care workers are getting paid a decent wage, and prohibit misclassification of workers as independent contractors rather than employees. There has been some important progress recently on all three fronts. Uh, first of first of all, this last legislative session, the General Assembly passed legislation to, beginning in January of 2026, prohibit independent contractor misclassification, which is a major step forward. Legislation also passed to improve data collection on home care workers and specifically their wages. Uh, we would consider this a partial victory as this is still only very high level data and in particular doesn't include any demographic characteristics that we could use to assess equity. And then finally, on raising wage standards, the federal government has taken administrative action that will make a major difference, but those actions are going to take several years, excuse me, to actually go into effect. And I think we're going to hear from our other speakers on what next steps are to build on this progress. Thank you so much. And now I am going to pass it off to April Sims, who will speak to her own experiences as a home care worker.
Hello, everyone. My name is April Sims. I've been in the healthcare field over 40 some years. As a home healthcare worker, we're underpaid, overworked, and it can get extremely stressful. Like, you're looking for government jobs now because the jobs that we have are not paying enough. You riding to work on gas money, and then you get paid, and then it seems like you have no money to pay your other bills, and people are trying to get out of the healthcare field to do other things that pay more money and less stress. You gotta love what you do. I love what I do. I've been doing it, like I said, over 40 some years. I started off as a caregiver, then became a CNA, GNA, then I became a med tech. I didn't want to go back to school to be a nurse. You can go back to school to be a nurse, but again, in the healthcare field right now, there's a high demand for people, and we don't have enough bodies to cover enough residents. And one thing, the quality care that the residents get. When you are one-to-one, it's very different. A one-to-one to me get more prestige than being in a nursing home or a hospital or any type of facility like that, when you may have 18 caregivers to one person. And I mean, 18 people to one caregiver. And that's not fair to the individuals, because there's no way we can get those people up and bathed and dressed right. You hitting and missing. Like, somebody may not get their teeth brushed. Somebody may not get a bath. You just gonna put deodorant on them, put their clothes on them. Because what are you gonna do? You one person to 18 people. The ratio for the caregivers are not there because the money is not there. And if we can get the money there, we can get the people. But the cost of living is so high right now. Who wants to work for $15 an hour? I mean, like, that's no money. Who can feed their family if they got a family of 8 over $15? Like, a lot of us are underpaid, stressed out. We're wondering how we're going to make ends meet. Some of us work 2 and 3 jobs only to make ends meet. We shouldn't have to work like that. And then we also need a union so that we can have somebody to fight for us. We need better health insurance, dental insurance. We definitely need to go to having a union so that we can get the money that we need to provide for the families. And then the families can get the care for the individuals that they need, because a lot of people, like I said, they're walking away from healthcare because there's no money. I mean, and it's stressful, very stressful. But again, I love what I do. I'm gonna do what I can do, and that's it.
Thank you so much, April. And I especially appreciate you mentioning the right to organize and join together in unions to advocate for yourselves and bring
Yes.
the power that comes with numbers. And now I think we'll pass it on to Sandy.
All right, let me just share my screen. All right, can everyone see my screen?
Yes.
Okay, all right. So good afternoon, everyone. My name is Sandy Ballin, and I am a staff attorney at Disability Rights Maryland on their Developmental Disabilities Healthcare Victims of Crime Act team. So just as a brief background about Disability Rights Maryland, Disability Rights Maryland, or DRM, we are Maryland's federally designated protection and advocacy agency for people with disabilities. So we are a nonprofit law firm, and we serve all Marylanders of all ages, all across Maryland, with all different types of disabilities. The work we do ranges from representing at eviction hearings to the work that the team I work for does, which is issues with Medicare and Medicaid services or access to DDA services. In addition to doing the legal assistance side, we also do a lot of policy work. So today I'm here to discuss the impact that home care related policies can have on individuals with disabilities, and specifically when it comes to access to care and the access to quality care that they can receive. So just also as a brief disclaimer before I begin, any information I do say in here is not supposed to be constituted as legal advice. It's more just for general informational purposes. So whenever I start discussing about anything related to disability rights, I always like to orient people in the disability rights movement, and specifically issues experienced by individuals with disabilities at a systemic level. So as we all know, individuals with disabilities have historically been discriminated against at that systemic level. The laws and policies that have been implemented, especially throughout the US history, have marginalized people with disabilities. For example, in the 1800s, there were the ugly laws that prohibited people with disabilities from even being seen in public. In 1927, there was the Supreme Court decision, Buck v. Bell, which allowed for the forced sterilization of individuals with disabilities. And to this day, that decision still has not been overturned. And that's not to say that in the disability rights world that there hasn't been momentum. Of course, there has. It really started with 1973 with the Rehabilitation Act. Section 504 was really the turning point because under Section 504 of the Rehabilitation Act, recipients of federal funds could not discriminate against an individual on the basis of their disability. And that was a really critical piece of legislation because for the first time, the rights of individuals with disabilities was being recognized. And of course, then in the 1990s, there was the pivotal Americans with Disabilities Act, or the ADA. And again, it served as a major point for recognizing the rights for individuals with disabilities. But despite having all of the pieces of legislation, and despite having the inception of Medicare and Medicaid and HCBS, and in 2010, the Affordable Care Act, individuals with disabilities are still being discriminated against. And that history of disability discrimination has resulted in segregation. It's resulted in isolations, and we've seen this in schools. There's a lack of access to medical care and support. There's also an ongoing bias, stereotypes, and low expectations for individuals with disabilities. And also, especially in the context of today's discussion, the discrimination that individuals with disabilities have faced has caused some of them to be institutionalized and to be forced to be in institutions just to receive the care that they need. And so in starting to discuss the access to care issue, the access to care really starts with what's known as the Olmstead decision. Elsie versus Olmstead, also known as Olmstead, was a 1999 Supreme Court case. And there were two women, Lois Curtis and Eloise Wilson, who had intellectual disabilities and mental health conditions. They were voluntarily admitted to the hospital for treatment, and they went through treatment, and then the healthcare professionals deemed them fit to receive services in the community, but they still remained institutionalized. And they had a court case, and it made it all the way up to the Supreme Court. And Supreme Court held that the unjustifiable segregation of individuals with disabilities was a violation of the Americans with Disabilities Act. And so what that meant is that individuals with disabilities had a right to receive treatment in an integrated setting, not within an institution, but within their community. And Olmstead really served as a critical turning point in promoting the use of home and community-based services through Medicaid. And the overall establishment of the Medicaid waivers in the US ensured that people with disabilities were able to have the supports and accommodations they needed that allowed them to live within the home and not be institutionalized. So just as a brief background about HCBS, in Maryland, there are different waivers that are available that provide for different services. But to receive HCBS, individuals have to be found both medically and financially eligible. But just because they're both medically and financially eligible doesn't mean that they automatically start receiving the services. There has to be funding available. And so what happens is individuals, once they're found medically and financially eligible, are placed on a wait list. And that is one of the biggest barriers that is faced currently for a lot of people who need the home and community-based services, is that they are placed on this wait list. And even once they're off that wait list, they're still receiving barriers to they're still facing barriers to even just receiving those home care services. And so what are the home care services? They're the supports and accommodations received within the home that allow an individual with disabilities to live within their home or residence. And so they rely heavily on home care workers and to provide them with what's known as activities of daily living, or ADLs. And ADLs are those basic skills needed to live everyday life. It's bathing, toileting, dressing, feeding. And so many of my clients rely on the home care workers to come into their home to provide them with those basic skills. And while many of my clients praise their home care workers and the work that they do for them, I also have many clients and many families who express hardship over receiving the care that they need. One of the biggest ones that I've seen from my clients, and I've heard from my clients, is home care workers not showing up for their shifts regularly. So if they're scheduled to show up on Monday, Wednesday, and Fridays, they only show up on Friday. Or if they're scheduled to show up starting at noon or at 8 a.m., they don't show up until noon. And family caregivers are then tasked with providing that care. And a lot of the times, the family caregivers are the ones who are contacting DRM for legal assistance. It places, when the unpaid family caregivers have to step in, it places added stress on them too, because they might not have the specialized skills to be able to assist their loved ones, or in some instances, the unpaid caregivers themselves are experiencing healthcare issues that prevent them from providing the care that is needed. And there's a lack of data on why these delays exist, which creates difficulty in determining how to avoid these delays. And additionally, and this is a common one that we've been seeing lately, is we've heard from home care workers that they're not being paid by the provider agencies. And as April said, home care workers themselves are underpaid and they're undervalued. And I've had clients who have told me that their home care workers have decided to resign from their position because they're not getting paid by the provider agency. And when I mean they're not getting paid, it's thousands of dollars in payments they're being owed, and they're not receiving that. And so finding home care workers in general also impacts the continuity of care, because if there's a high rate of turnover by the home care workers, consumers are having gaps in the services as they search for the home care workers that meet their needs. And additionally, there is a lack of tools and specialized skills, and this goes to the quality of care concerns that might exist. Working on the developmental disabilities team, many of my clients have intellectual and developmental disabilities. And so they experience behavioral issues. They don't communicate in what's referred to as the traditional way. They are nonverbal. And what we've heard from clients is that their home care workers do not have the specialized skills, or they lack the tools required to work with the individuals with those disabilities. And they're not being provided that training and that opportunity to grow their skills to be able to provide that quality. And so individuals with disabilities who require these home care workers to be able to communicate with them effectively, it serves as a barrier for that participant to receiving the quality care that's suitable for their needs and addresses their concerns. And so overall, working in the disability rights world, we've seen that these are the common barriers that are faced. Individuals with disabilities rely on home care services to avoid institutionalization. And for some individuals, they feel that because they're not getting the home care work or the home care that they need, it's forcing them to go into the institutions that they really don't want to. So here's contact information in case anybody has any additional questions after the presentation. But I think I'm going to hand it back to Chris.
Thank you so much, Sandy, and thanks again to April. Those were both very informative remarks. We are now going to move on to Q&A. And just a reminder that questions can be submitted via text in the Q&A function. So far, we have 2 questions, so hopefully we'll get a few more. But before that, I'm going to start it off by cutting in line and asking my question. So I talked some about recent progress that we have made in improving our policies around Medicaid-funded home community-based services. How can state policymakers build on that progress, and what are the next steps, the next things that need to be done to improve job quality and access to care? And either of you can start us off.
I mean, I don't mind starting off. From our perspective, as I was saying, with the individuals with disabilities, I think one of the ways that they can do it is obviously by providing those opportunities for training and the opportunities for growth to be able for the home care workers, so that they also feel supported in their work. Because if they feel supported in their work, they're able to provide the quality care that they might not be able to provide right now because they're not feeling supported in their work and because they're not being provided those opportunities.
Mm-hmm. Thank you. And April, anything from you on next steps? I know that you spoke earlier about the importance of the right to organize.
It's very important that we get a union started immediately, or we're going to lose a lot of healthcare workers, and families are going to be scrambling around to find help for their loved ones when there's the opportunity to keep the healthcare workers, but you got to raise the wage. You definitely have to raise the wage, or people's going to give up.
Thank you. And so I'll move on to the audience questions we've gotten so far. We have one very inquisitive audience member. Everyone else also strongly encouraged to submit questions. And I'm going to go out of order. From Jim Kuntz, we have a question about are home care workers currently legally prohibited from unionizing? And if not, what are the barriers to it? So yes, domestic work, which includes essentially any jobs performed in private households in the private sector, are under federal law not protected and not authorized to form a union. Because that is not authorized under the Federal Labor Relations Act, that is actually an area where states do have authority to act on their own. So one important step that state policymakers could take would be to independently create state level authorization for a right to organize for home care workers. I think there is some level of gray area around that, but creating state authorization is certainly the biggest step that would clarify that. Sandy or April, I don't know if you have anything else to say about, okay. Moving on to another question from Jim. Has legislation ever been introduced to require racial equity analysis in the budget process? The answer to that very narrow question is no. There has been legislation at the state level to require racial equity analysis of legislation, generally in fairly narrow areas, such as legislation relating to the criminal legal system. So our recommendation differs from those past bills in that it applies specifically to the budget process, and we're recommending that that be done comprehensively. Obviously, we recognize that policy often does not move forward all at once. We support those bills to move incrementally on legislation. Budget equity analysis has been one of the first steps that many other jurisdictions have taken along this route. Then moving on to a third question from Jim. Is this the same situation as custodial nursing care, where folks on Medicare have to spend down their savings until they're eligible for Medicaid? So would a federal solution be to expand Medicare to cover home and community-based care? The short answer to those are yes and yes. In general, Medicare currently does not cover long-term care, with some narrow exceptions. So anyone on Medicare or not on Medicare, in order to qualify for any kind of public support for long-term care, needs to either have low income or combination of extremely high medical costs and low assets. And so, yes, expanding Medicare to cover long-term care, both institutional and at home, would be a major positive step to expand access to care. I would say two things that need to go along to make that work are first making sure that out-of-pocket costs are reasonable. Unlike Medicaid, Medicare does include things like deductibles and copays. So we would still need to make sure that those out-of-pocket costs are low enough to make it meaningfully affordable. And then second of all, again, we need to make sure that those are jobs that pay a living wage, that include a right to organize, and that are generally valued, to make sure that we have the workforce necessary to provide that care, even if it is covered. And I will say that Vice President Harris has made a proposal to expand Medicare to cover both institutional and home and community-based long-term care. We now have a comment from, or actually, I do just want to check, do either of our other speakers want to comment on expanding Medicare to cover long-term care? Excellent. All right, moving on to a comment from Patty Nichols. I've worked as an RN in home care for 20 years. The home care worker has no control over the environment, often does not have the body mechanics, protective devices that they would have in a facility. They're exposed to secondhand smoke, get bit by dogs. Thank you, Ms. Sims, for your service. Strongly agree on all of that. Thank you, April.
You're welcome.
On the front lines. Do we have any other questions? Can home care workers join existing unions? Is there a state representative that has been receptive? So again, under federal law, any domestic workers, which typically would include home care workers, cannot join a union. That is something that would need to be authorized under state law. I don't believe that there has been legislation advanced so far to expand collective bargaining rights for home care workers. I think one reason for that is that strategically, a lot of the legislation that has been proposed has been through collaborative work that combines advocacy from workers and consumers and agencies. And one of those stakeholders is less excited about collective bargaining than the others. Who would you recommend a legislator or candidate contact on this? I'm not totally sure I understand that question. Certainly, you know, any Maryland resident should talk to their own legislators. And then in terms of who legislators can talk to, policy experts, that would, yeah, definitely talking to us, Sandy at Disability Rights Maryland. I also think that people to talk to would include the Public Justice Center and 1199 SEIU, who's been doing a lot of great work on this. I should say at the Public Justice Center, usually I would name Dave Rodwin, but he is moving out of that role. There are definitely other people there who are taking over, but I don't have their names in front of me at the moment. Do we have any other questions? I'll leave it open for a couple minutes. Well, seeing no other questions, it looks like we are going to be handing about 17 minutes back to all of you. I want to thank all of our attendees for joining us today. It's been a small group. I hope it's been informative. I know that I learned a lot from our two speakers. I want to definitely thank both April and Sandy for joining us. I've really appreciated the insights that you've brought to us. Any final words from either of you? We'll start with April. Any final thoughts?
I just want to say that we need to keep each other encouraged, those of us that are home care workers, as far as holding out a little bit, hoping that the pay is going to go up, hoping that we can keep people working. Because if not, what are the people loved ones going to do? I mean, they need us. They really do.
Thank you. Sandy?
I'm gonna echo that keeping the faith and keep working towards it. It is a long fight, and it's gonna be a hard fight to be able to ensure that all of the players in the home and community-based services are getting the services that they need, but also that their rights are being respected. So keep the faith, basically.
Well, thank you both so much for speaking to us today. And I want to thank all the attendees for joining us. We'll hand you back your 16 minutes, and I hope everyone has a lovely day and week.
You as well. Thank you.
Thank you.